Welcome to our ICU on primary angle closure disease. I am Dr. Roshini. I am a glaucoma consultant at Chaitanya Eye Hospital, Trivandrum. We have Dr. Sheldon James, who is Professor and HOD at Karakona Medical College as moderator. Welcome, sir. Our panel include Dr. Sarita VK, who is additional professor at Government Medical College, Kottayam. Our keynote address is by Dr. Thomas George. He is a senior glaucoma and cataract consultant at Chaitanya Eye Hospital, Trivandrum. He will be giving his thoughts on clear lens extraction in primary angle closure disease. Welcome, sir. We have Dr. Kiran Gopalakrishnan, who is a senior glaucoma and anterior segment surgeon at Precise Hospital. He will be giving his talk on trabeculectomy. Welcome, sir. Let us move on to the topic. Globally, the primary angle closure glaucoma, the prevalence ranges from 0.1 to 2.7% among various ethnic groups and is most prevalent among Asian population, including India. In India, the prevalence of primary angle closure disease is varied. It ranges from 0.5% to 4.3% as reported by various population-based studies done in South India, West Bengal, as well as Central India. And this varied prevalence is because of the difference in the definitions used for angle closure disease, that is occludable angles as well as primary angle closure glaucoma. There is a significantly high incidence of PACD in India, and the estimated burden of PACD cases in India is 21 million. And PACD forms almost half of all adult primary glaucomas in a hospital setting. What differentiates primary open angle glaucoma? Angle closure glaucoma from open angle glaucoma is the iridotrabecular contact, which can be temporary or permanent, causing obstruction to the aqueous outflow and acute or chronic elevated IOP, resulting in a glaucomatous optic neuropathy. Certain eyes are predisposed to angle closure disease. These are anatomic as well as genetic risk factors: smaller corneal diameter, shallow central AC depth, shorter axial length, thick lens and increased lens vault, anteriorly positioned lens and increased lens thickness axial length ratio are few risk factors. These are common in hyperopic eyes. Other risk factors are thicker and anteriorly inserted peripheral iris, prominent anteriorly displayed ciliary process, old age, female gender, Asian and Inuit ethnicity, and family history of glaucoma. There are various mechanisms of angle closure, the most common being relative pupillary block. There is an apposition of anterior surface of lens and the posterior surface of iris in a mid-dilated pupil stage, resulting in blockage of aqueous humor circulation. There is bowing of the peripheral iris, trabecular meshwork, and iris contact and angle closure. This can be an appositional contact which is reversible, can be a prolonged iris trabecular meshwork contact which results in peripheral anterior synec and permanent closure. There are non-pupillary block mechanisms as well. A crystalline lens plays an important role in primary angle closure disease. High lens vault, which is independently associated with angle closure after adjusting for age, gender, anterior chamber depth, and lens thickness. Lens thickness axial length ratio is greater than normal in most age groups with angle closure glaucoma. Plateau iris configuration also needs special mention. It is seen in 30% of eyes in at least one quadrant in PACG in Indians. It is related to forward displacement of the ciliary process, causing anterior displacement of the peripheral iris and angle closure. It can be a complete plateau or an incomplete plateau. A complete plateau, there is closure to the level of the Schwalbe line leading to high IOP. An incomplete plateau, there is a closure to a level onto the trabecular meshwork, and IOP may be normal, but peripheral anterior synec will develop over time. A plateau iris configuration is diagnosed by indentation gonioscopy, which shows a double hump sign, the peripheral hump being the ciliary body pushing the iris root, a central hump being the iris resting over the lens surface. Ultrasound biomicroscopy is also diagnostic. It shows an absence of ciliary sulcus as well as larger or anteriorly rotated ciliary process. Other mechanisms are high iris insertion or thick peripheral iris, suprachoroidal effusion, which needs mention, especially in bilateral acute angle closure glaucoma caused by drugs, which also present with transient myopia, the main culprits being topiramate, acetazolamide, cabergoline, promethazine, etc. Malignant glaucoma is also important. Though the mechanism is unclear, there is forward rotation of ciliary process, effusion, choroidal expansion, and posteriorly directed flow of aqueous into the vitreous. In that case, a patent iridectomy should be there to rule out pupillary block. Coming to the clinical spectrum of primary angle closure and its glaucoma, The clinical spectrum has been explained under can be explained under two headings, the classical classification as well as the modern classification. Classical classification has three entities, subacute, acute and chronic glaucoma. In subacute primary angle closure glaucoma, patients will have an occluded double angle. There will be intermittent and self-limited intraocular pressure elevations with symptoms of headache, halos and blurred vision, and normal IOP in the interparoxysmal period. Acute primary angle closure glaucoma, patient will have congestion of the eye, corneal edema, mid-dilated pupil, blurred vision, and may be accompanied by nausea and vomiting. It can be a medical emergency also. Chronic primary angle closure glaucoma, there is peripheral anterior synechia of more than 180 degrees and a chronically elevated IOP. And some patients have no symptoms as in creeping primary angle closure glaucoma where there is a zipper-like slow closure of the angle, whereas others complain of headaches occasionally. The newer classification is popularly known as the ISUO classification, which is also recommended by the American Academy of Ophthalmology and World Glaucoma Association with the addition of a plateau iris configuration to it. It classifies glaucoma into primary angle closure suspect, primary angle closure and primary angle closure glaucoma. Primary angle closure suspect, in primary angle closure suspects, there is non-visibility of posterior pigmented trabecular meshwork for more than 180 degrees in primary position on gonioscopy, done in a dark room with 1 mm slit width. Patients will have normal IOP, normal optic nerve head and visual field. These patients are at risk of subsequent primary angle closure and the 5-year progression rate is 22%. Primary angle closure occurs in eyes with PACS and they have evidence of peripheral anterior synechia with or without elevated IOP, sectoral iris atrophy or glaucoma flake and lens opacities. This entity is caused by pupillary block and this exists in an acute stage or a chronic stage or acute superimposed on a chronic stage. And the fellow eye is at risk and there is risk of developing glaucomatous optic disc damage with high IOP. And PAC progresses to primary angle closure glaucoma with characteristic optic nerve head and visual field changes, and the 5-year progression rate is 28.6% if untreated. PAC exists in two stages. It can be an acute stage or a chronic stage. Acute primary angle closure is also known as acute angle closure crisis, popularly known as the acute angle closure attack. Here the entire circumference of the angle is obstructed suddenly and there is a rapid IOP rise to high levels. There is pressure-induced corneal edema, vascular congestion, eye pain, headache, nausea, vomiting. It will be an ophthalmic emergency. Untreated, permanent vision loss and blindness will occur. In a chronic primary angle closure, there will be continued slowly progressive closure of the angle, eventually leading to sustained elevation of IOP and progression to glaucomatous optic neuropathy. That may not have any of the findings of acute angle closure. And asymptomatic chronic PAC may lead to severe visual field loss. Plateau iris configuration, plateau iris syndrome needs special mention. It is often difficult to distinguish from PAC entities resulting from pupillary block. This is a non-pupillary block mechanism. In a plateau iris configuration eye, there will be near normal central AC depth, flat iris profile, anteriorly positioned ciliary body, crowding of the anterior chamber angle by iris base. IOP may be normal or elevated. Iridotrabecular contact will persist even after a patent laser iridotomy. And plateau iris syndrome, any iridotrabecular contact persisting after a patent laser iridotomy in an eye with plateau iris configuration showing IOP elevation on pupillary dilatation is plateau iris syndrome. Patent iridotomy will eliminate any pupillary block component. IOP typically increases after pupil dilatation, which causes greater occlusion of the angle by the peripheral iris. Last but not least, gonioscopy, it's very important. It's a game changer. It differentiates open angle glaucoma from closed angle closure glaucoma. And gonioscopy of both eyes should be performed on all patients in whom angle closure is suspected to evaluate angle anatomy. Compression or indentation gonioscopy with a 4-mirror lens for differentiating appositional closure from synechial closure should be done, and also for evaluating the extent of peripheral anterior synechia. This should be done in a semi-dark room at the slit lamp by a trained ophthalmologist. To conclude, primary angle closure glaucoma causes blindness in a greater proportion than in affected individuals than open angle glaucoma, and the condition is often overlooked in general practice. Need for routine gonioscopy should be stressed. Thank you. Next we will have Dr. Sarita VK. She will be presenting role of YAG-PA in angle closure disease.
Good afternoon everyone. Thank you Dr. Roshini and the organizers of Drishti 2022 for giving me the opportunity to be part of this session. Straight to my topic, fire and rescue, role of YAG peripheral iridotomy in primary angle closure disease and management of acute angle closure attack. The first line treatment of primary angle closure disease is laser peripheral iridotomy because it is relatively non-invasive and has a favorable risk-benefit ratio. From the schematic diagram shown, it is clear that a patent peripheral iridotomy, it prevents a relative pupillary block. This is a UBM picture. In the second figure, you can see the patent peripheral iridotomy. The angle has widened and the iris has become flatter. Coming to the indications of laser peripheral iridotomy, the absolute indications are primary angle closure and primary angle closure glaucoma. And in case of acute angle closure, first of all, you have to reduce the intraocular pressure with systemic as well as topical medications. And once the cornea has become clear, you can do a laser PI. The prophylactic indications are you have to do laser PI in the fellow eye of acute angle closure if the angles are occludable, because there is a 50% chance of progression to acute angle closure within a 5-year period, as evident from the studies. Shall we do laser PI in all cases of primary angle closure suspect? No. Only in high-risk cases of primary angle closure suspect, we have to do laser PI. Like if there is a family history, or if the patient is a one-eyed, and if the patient requires frequent dilation for retinal evaluation, and if there is a history of rise in IOP after dilation, and in case of non-compliant patients and patients who cannot come for regular follow-up. And also you have to do laser PI in case of plateau iris configuration to counteract any element of relative pupillary block. Usually we use two types of lasers, Nd:YAG as well as argon. We prefer Nd:YAG just because it is faster, it has got a quick cutting action, it has a photo-disruptive effect. But the main disadvantage is that it may bleed, especially in case of patients on anticoagulants. And it is very difficult to do laser Nd:YAG PI in case of a thick peripheral iris with no crypts. So in those cases, you have to supplement Nd:YAG laser with or pre-treat the iris with argon laser, which has got a coagulative action, and the chance of bleeding is much less compared to YAG laser. Coming to the preparation, you have to get a written informed consent before the procedure. You can apply 2% pilocarpine to stretch the peripheral iris, and it has to be thin. Then you have to apply 3 times at an interval of 15 minutes and 1 hour before the procedure. You can apply topical brimonidine to prevent the post-procedural IOP spike. The patient has to be seated comfortably, anesthetize the cornea. You have to use a contact lens, and we usually use Abraham lens, which has got a +66 diopter plano convex button. What are the advantages? It acts as a speculum, it keeps the lids apart, and it minimizes corneal burns and focuses and increases power density on iris, and it also magnifies target site and tamponates bleeding. If there is bleeding, you have to press with the contact lens at least for 30 seconds. In most of the cases, the bleeding will be prevented. Coming to laser parameters, it is fixed for a particular machine, and the usual energy range is 48 millijoules, 1 to 3 pulses per application, and the spot size is 50 microns, 1 to 6 shots, and in most of the cases, a single sitting is needed. The slit lamp should be set at a high magnification, and you have to identify a crypt or a thinned out area in the superior peripheral part of the iris. Avoid the site where the lid bifurcates the cornea, because it can produce serious or visual disturbances after the procedure. The aiming beam, which is a helium neon beam, it is brought to a focus single point onto the iris crypt and focus on the anterior iris stroma rather than on the surface of the iris to get the maximum photo-disruptive effect and also to avoid damage to the lens capsule. The end point is there will be a sudden gush of aqueous and pigment with a deepening of the anterior chamber. Ideal size is 150 to 250 micron, and you have to visualize a lens capsule, not rely on the red glow, because retroillumination may give false impression of patency. What will you do if you get a lamellar peripheral iridotomy? You have to repeat at the same or a different site after 1 week, once the inflammation has subsided. This is a short video showing the progression of the formation of a peripheral iridotomy. with Nd:YAG laser. You can see the shots hitting and a beautiful peripheral iridotomy has been created. Coming to the post-laser management, you have to apply again alpha agonists like brimonidine to reduce the post-procedural IOP spike, measure intraocular pressure after 1 hour and 1 week because it is the time for the IOP spikes to occur, then topical steroids to counteract inflammation 4 times daily for a week, reassess AC depth gonioscopy, and check for the patency of the PI after 1 week, and dilate the pupil once the PI is patent to look for any posterior synecdoche, and also you have to evaluate the optic disc status. Coming to complications, these depends upon mainly on the total energy required, and one important is dysphotopsia. Patient may complain of linear dysphotopsia, but studies have suggested that it is irrespective of the site of the laser PI. Suppose if laser PI is not performed or if it is not possible, what will you do? You have to educate the patient about the symptoms of acute angle closure and to avoid medications causing pupillary dilation like sympathomimetics and parasympatholytics. Other options are surgical iridectomy, which has got its own complications. And again, you can rely on argon laser peripheral iridoplasty if it is available. Coming to my second topic, acute primary angle closure management. It is definitely an ophthalmic emergency. The pathophysiological mechanisms have been beautifully illustrated by Dr. Roshini. Coming to the treatment goals, the main treatment goals are to relieve the pupillary block. Second is to lower the intraocular pressure and associated pain, inflammation, nausea, vomiting, etc. The medical management, you have to take a brief history, check whether there is any cardiac or renal failure, and examine. You have to have an idea whether the angle closure is due to relative pupillary block or plato iris or the retrolenticular causes. If the IOP is very high, you can start on systemic medications like oral carbonic anhydrase inhibitors, acetazolamide, 5 to 7 milligram per kilogram body weight. Then 20% mannitol also may be started. Then topical, simultaneously you can start on anti-glaucoma topical medications like beta blockers, timolol, again dorzolamide, and alpha agonists like brimonidine. What is the role of pilocarpine? It improves outflow once IOP is lowered enough to restore iris perfusion. You can start in the initial part itself, but it acts only if the iris has retained this perfusion. But it may produce paradoxical AC shallowing if the cause of angle closure is the lens. You can start on topical steroids to treat the inflammation, systemic analgesics, antiemetics, and if it is the pupillary block is not relieved and if the IOP is remaining high, you can even indent the central part of the cornea with a gonioscope or with even a bud. It may sometimes facilitate outflow. And anterior chamber paracentesis, it is controversial. It is up to the discretion of the treating surgeon. The laser peripheral iridotomy is the definitive treatment to relieve pupillary block. It should be performed as soon as possible. And don't forget to put a prophylactic PA in the contralateral eye. Other surgical interventions are surgical iridectomy, trabeculectomy, primary cataract extraction with or without goniosynechiolysis, which depends upon the amount of optic nerve damage and the associated visual field damage. Follow-up is 48 to 72 hours, 1, 6, and 12 weeks, and every 12 months. The take-home message is primary angle closure disease is largely undetected. It causes twice the proportion of bilateral blindness when compared to open angle. Do gonioscopy in all glaucoma patients. Do laser PI in indicated patients with primary angle closure disease. Your timely intervention can prevent a person becoming blind. Thank you.
Thank you, ma'am. Next session will be trabeculectomy by Dr. Kiran Gopalakrishnan.
Thanks, Dr. Roshini, for the invite to speak here. So I'll be discussing about a few surgical pearls in trabeculectomy in the context of angle closure disease. Now, trabeculectomy has been the most popular filtration surgery for angle closure glaucoma for good reason. Studies performed in the long term in whichever geographical area you choose. As you see here, a study in South Korea over 15 years has a qualified success rate of about 75%. A study published from RP Center in India has a qualified success rate of 88% at 10 years. So this is an amazingly successful surgery. But even in the best hands, trabeculectomy has its complications. Now, if you look at the primary TVT study, which only dealt with trabeculectomy in open angle glaucoma patients, but I put it here because even in open angle glaucoma patients, trabeculectomy in the hands of some of the best glaucoma surgeons in the world still has a reasonably high complication rate of around 41%, out of which 33% were early complications, and most of which could be managed in the office itself. But there were around 8% of patients with serious complications like vision loss and people who had to be taken up for resurgery. So which complications are more likely to occur in angle closure glaucoma traps compared to open angle glaucoma traps? You are at higher risk of developing a shallow or a flat anterior chamber. You are more likely to encounter aqueous misdirection or malignant glaucoma, and the cataract formation acceleration is again much faster in traps in angle closure disease. So we will try and look at certain surgical pearls, which are basically steps that you would do in any trap, whether it is open angle or angle closure, but has special emphasis on angle closure glaucoma traps. First is preoperative mannitol. Now, mannitol dehydrates the vitreous and therefore can have a good impact on reducing the positive pressure during surgery. And this will basically make your surgery a little more smoother and less messier if you have less positive pressure during surgery. And the important thing to note is that its peak action is in about 30 to 60 minutes. So you don't want to give the patient mannitol 3 hours before surgery or too late before you take the patient up for surgery. And the dose is about 20 ml per kilogram body weight. And since the drug induces diuresis, it's always a good idea to tell the patient to go to the bathroom before you take the patient up for surgery. In older patients, I usually suggest diapers, because the positive pressure reduction that you obtain from mannitol can be counteracted by the straining if the patient is on the table and is straining to pass urine. Now, second is optimizing the use of mitomycin C. Now, how can you optimize mitomycin C use? There are two things here: concentration and exposure time. So various concentrations have been studied, less than or equal to 0.1 milligram per ml, 0.2, 0.4 and above. So multiple publications have looked upon this. And generally you find that at less than 0.1 milligram per ml, the efficacy of your traps actually become low in terms of its success rates. At 0.4 and above, the complications tend to become higher. All the complications I described above are going to be likely higher with 0.4 and above. And therefore a reasonably good compromise of concentration will be 0.2 milligram per ml. And as far as exposure times are concerned, 1 minute, 2 to 3 minutes and 3 to 5 minutes have been looked at in multiple publications. Generally in less than 1 minute, the efficacy actually is lower. At 3 to 5 minutes, it usually makes no difference because the tissues are already completely saturated with mitomycin by around the 2 to 3 minute time frame. So again, 2 to 3 minutes seems to be a good compromise. If you are using injectable mitomycin, which in preliminary data does show equivalent efficacy to using sponges, then this may not be of, this exposure time may not be of such significance. Now coming to scleral flap creation. Now the important thing to note when you create this scleral flap is you should not end up with a thin scleral flap because the risk of shallow flat chambers hypotony is going to be much higher in a thin scleral flap. So you should obtain a reasonable plane of at least 50% or more scleral thickness. Now you can do the scleral flap in multiple ways. You can basically initially get a good plane. I use a combination of both tunneling. I don't usually tunnel all the way right up to the cornea, but I use a combination of both tunneling and some degree of dissection under direct visualization as the scleral flap becomes closer to the trabecular meshwork. Irrespective of the technique, make sure you get a thick scleral flap. A pre-placed suture. Now this seems a very innocuous step, but a pre-placed suture helps you to basically close the flap much faster once the sclerostomy is made. Because once the sclerostomy is made, the eye tends to become hypotenuse. It's much more difficult to pass the suture. And this shallowing of the chamber post-sclerostomy creation is going to be much more prominent in an angle closure trabeculectomy. Next, again, a simple thing, paracentesis. Before you create the sclerostomy, just make a paracentesis. Now, once you do the sclerostomy, as I said, in angle closure glaucomas, the shallowing of the chamber can be quite aggressive, and you have to now reform the chamber. The sclerostomy opening is much larger in size compared to the paracentesis opening. It's easier to reform the chamber through a paracentesis opening. So it basically gives you much better control of the anterior chamber intraoperatively, and postoperatively, if you want to reform the chamber in the case of a shallow or a flat chamber, it is easier to use the pre-existing paracentesis rather than create a new paracentesis in the setting of a hypotenuse flat eye. And some people do chamber reformation in the office itself, in which case you have to basically look at the direction or the clock cover where you are going to create paracentesis and make it about 3 o'clock in the left eye and 9 o'clock in the right eye to facilitate easy access from the slit lamp. When you make the sclerostomy, whichever technique you use to make sclerostomy, whether using a punch or whether you are making a sclerostomy using the technique I show here, where I use a sharp MBR blade to delineate the two sides of the sclerostomy and then use an angled vanas to make the intervening cut, you make sure that you go slightly anterior and not end up damaging the root of the iris and the ciliary body. This will accelerate the risk of hypotony and also increase the risk of aqueous misdirection in the postoperative phase. Releasable sutures. Now, releasable sutures, there are various techniques of using releasable sutures. Once you make the scleral flap, you close the scleral flap with either only releasable sutures or a combination of both interrupted sutures and releasable sutures. There are various techniques. I am not going to the details of the techniques, but I tell you that the use of releasable sutures in angle closure glaucoma traps, especially in all traps in fact, is a no-brainer, because there is clear literature evidence, and everybody who has put releasable sutures will attest to their own personal experience as well, that the rates of hypotony, flat chambers, choroidal effusion, all these can be reduced by sometime between as much as 2.5 to 4 times if you put releasable sutures. Now, you can wonder, if I put scleral flap sutures very tight and make a large number of sutures to close the scleral flap tightly, also you can reduce the risk of hypotony, flat chambers and choroidal effusion, but that would actually impact the success of the trap because it will interfere with filtration. But with releasable sutures, the complete and qualified success rates are not altered. So it reduces complications and maintains success. The twin things that, is the holy grail of any procedure. Cycloplegic therapy. Now, it's always a good idea to give a subconjunctival dash of atropine at the end of an angle closure glaucoma trap. And the reason why I say is, aqueous misdirection or malignant glaucoma is so much more common in angle closure glaucoma traps. In fact, this study retrospectively looked at 27 consecutive cases of malignant glaucoma and found that all of them had a primary diagnosis of angle closure glaucoma. And when they looked at the UBM images of the fellow eye, all of them had an anteriorly rotated ciliary body in the fellow eye as well, which means the other eye, whenever it undergoes trap, is going to be at higher risk of malrotation. So intraoperatively, subconjunctival atropine plus postoperative cycloplegic therapy for a couple of weeks is a good idea in angle closure glaucoma traps. And finally, if the patient with angle closure glaucoma has a whiff of cataract, whether it is a very advanced cataract like this, where you're obviously going to take out the cataract, but even with much lesser cataracts, lens does contribute significantly, and it's always a better idea to do a cataract surgery first and then go ahead with the trap at a different site, as I do. But irrespective of the contribution of the lens, post-operatively, your life is much more easier once the lens is taken out in a trabeculectomy, because it will reduce the risk of flat chambers and hypotenuse eyes. To conclude, while you look at 8% serious complications, you have to look at the 88% success at 10 years. And you think that these are patients who would have actually gone blind by 10 years because they were offered trabeculectomy in the first place because there was no other option. So all of these patients, almost all of them at 10 years would have gone blind if not for the success of trabeculectomy. Thank you.
Thank you, sir. That was indeed informative, especially for those who struggle with trabeculectomy in angle closure disease. Next, we will have the keynote address. Let me welcome Dr. Thomas George. Dr. Thomas George is a senior consultant at Chaitanya Eye Hospital. He has more than 20 years of experience in glaucoma and cataract practice. He will be giving his thoughts on clear lens extraction in glaucoma, angle closure glaucoma.
Thank you, Roshini. And I will go through the relevance of clear lens extraction and the scientific evidence that is in literature so far. So essentially, primary angle closure was very simple till last 2 decades ago. It was relative pupillary block, iridectomy or iridotomy, laser being easier, do a PI, and that's the end of story. But now we have data coming in that makes us ask these questions. Do we need it? Does the PI really work? And things like that. And we've been getting evidence over time. Most of it's already been presented in this session so far. The Valorai survey, which was probably the first one to flag this, they showed progression data. The PACS progresses to PAC, and none of the PACS actually progressed to PACG, so the absolute risk of glaucoma itself in terms of optic neuropathy is less. 11% of those who underwent PI also progressed to PACG. So PI is not the final answer. Chennai glaucoma study again found an incidence for primary angle closure disease that's people deemed normal, moving at least to PACS after 5 years, and that was 4%, and most of these had only reached PACS, and that's still not visually threatening. So with these population-based studies, we knew that PACG incidence is low even in PACS or PAC. PAC means the Synechiae, PACS means it's occludable angle alone. PAC could have intraocular pressure above 121 also. And PI does not protect everybody. So that set the stage for the next 2 trials that have come out recently, that's ZAP and Analyst. And ZAP is a Chinese study, based in China, Zhongshan angle closure prevention trial. A large number of people were screened for eligibility, and 870 subjects were picked up who had PACS in both eyes, PI in one eye, and the other eye as control. Takes care of all the biases that could be at a personal level, and a 6-year follow-up was done. They did OCT on around for 454 patients, that's around 500 patients, and they found that in 26.4, that's 1/4 of the angles that underwent PI did not open up at all. And angle closure, primary angle closures at Synechiae or a high IOP noted in the 6 years follow-up occurred, they converted it to eye years, so 4.19 in 1,000 eye years in the treated eye or the PII, and 7.97 in 1,000 years, eye years in the untreated or the control eye. So absolute numbers are 19 and 36, that doesn't matter. So essentially half the patient, the incidence of progression was reduced to around half. And the PAC, incidence of PAC in PACs is low, PI does not protect, it doesn't seem to have added anything, but then we know now that the risk is reduced by half, reduced to half. Analysis was actually done by investigators which are common to ZAP, but in Singapore, they had access to more funds and they covered for a lot of shortfalls of ZAP, and similar one eye PI, other eye control, around 500 individuals, 50 plus, 2-quadrant apposition was a requirement, PI in one eye and the other eye control. So results were in 5 years, 5% with PI progressed, and compared to without PI, it was double that number, 9.4. So essentially PACS to PAC, PI 5%, without PI 9.4, and most of these are developing a Synechiae and not high IOP. So there is more to it than just pupillary block, which a PI is expected to deal with. So that brings us to another set of studies which have also been in the realm for about 10 years. That is the lens vault. So, wait a minute, yeah. This is what it is. You have the scleral spur to scleral spur. Once the OCT came, we could measure this distance. That's called the lens vault. And Singapore's group found that in PAC and PACS together, they had a higher lens vault. And the Korea group found that the lens vault was above 1 in PACG as opposed to normals. So lens probably contributes to the whole situation is now what we started postulating, and then the Eagle study came by. The Eagle study, it concluded that lens extraction was more cost effective than doing a laser PI. This is actually the NHS costing because the medications and things like that get costed there, which we don't think of as cost in our situation, for PSC and PACG. I have quite a few issues with it. I will not spend much time on the issues. So essentially it's a multi-center trial, early lens extraction for treatment of primary angle closure glaucoma, 50 plus age group, and primary angle closure with 30 mm or more pressure, or PACG, that's optic neuropathy with 21 or more pressure. No cataract clinically and no previous history of acute angle closure. Randomized to either PI or to lens extraction. The study was, in their own write-up, was expected to, I'm going back. Was expected to pick up a difference of 1.75 mmHg, and they found a difference of 1.18, which actually should not be reported, and they came to these conclusions. That's one of my issues. The other issue is they found more complications in the PI group, and if you look at the table that they're given, 16 of these 50 complications is hyphema. You see blood oozing out of PIs all the time. 10 did not tolerate the anti-glaucoma medications, they continued after that, and 12 needed cataract surgery during follow-up for whatever reason. So essentially we are looking at trivial complications being highlighted. Notwithstanding all this, Eagle study got us thinking about the lens as a culprit. I would prefer to say it is probably part of the solution rather than the culprit. Let me just take you through two cases where I have dealt with the lens primarily. Here's a 53-year-old lady. She's on antipsychotics. She's a very interesting person because for 2 years she noticed she was losing vision in one eye and did nothing about it, till she became hand movements vision in that eye. And then she decides to seek help with an ophthalmologist. She's a literate person, a gazetted officer, not some Muniyamma sitting in some village or something. And that is why it's interesting. And lo and behold, pressures of 40s in both eyes, gonioscopy, no angle structures seen, opening only to posterior trabecular meshwork on intendation. One eye is gone, 0.9 pale, other eye is 0.4 minimal pallor. PI both eyes, made no difference to the IOP, uncontrolled on 4 AGMs, and ASOCT showed a high lens vault, and considering her situation of being one-eyed, other eye is going, even with the PI, we have not opened it up. We went for a clear lens extraction, and her pressures have been controlled since 10 mmHg. She has refused surgery in the other eye, so the blind eye is still blind, or rather hand movements also is gone. Anyway, that's what it is. You're looking at a high lens vault closure, and that's a UBM showing that there is a ciliary process sitting there also to add to the problem. Anyway, on follow-up, this is what happened. The angle that looked like this opened up. Obviously, the lens has moved away. There's more space. Angle that looked like this opened up to this. And these are the UBMs, ASOCT. This lens vault becomes this because the IOL is 2 mm thickness compared to 4.5 of the lens. And it obviously falls back. And out here, it's actually trap meshwork is open to the aqueous. And that made all the difference. It does work. Case 2 is a 62-year-old diabetic who did not have the advantage of Eagle. First time around, she went to another hospital, and acute closure, laser PI done, didn't work. So obvious thing to do in those days was to do a surgical PI, and then on many medications, her pressures were controlled, bad follow-up, and eventually she reaches us with 0.9 cup in one eye, 10 mmHg on latanoprost for cataract surgery. She had good cataracts there, so I didn't have a problem deciding here. Anyway, this is what it was. And once again, she had a huge, our previous case had 1.1 lens vault, and look at this lens vault, 1.6, huge lens vault. This would have been the ideal case to have had a lens extraction when she didn't even have the cataract. Anyway, doing that, once again, even with a long-standing closure, post-lens extraction, it opened up. So there is a definite case for lens extraction, but I wouldn't say everybody. I would say PACS observe because the incidence is less, but if the patient can't come back, do a PI. Either way, you are justified. You got evidence in the literature for that, but gonioscopic follow-up is mandatory. PAC, once again PI, document the post-PI gonioscopy, open, just follow up, closed, you need close follow-up, angle imaging, look for PACG to start up. That is pressures going up with optic neuropathy. And if you have, this is my own algorithm which I'm saying, it's not from the literature. PACG, PI, IOP controlled, no significant sinus lens vault or plateau, just need follow-up. Significant sinus, it's a worse disease, you have a low threshold to start medications as well, and consider early cataract surgery as and when the cataract appears. If medical therapy fails, surgery, if there's more than 180-degree PAS, I would tend to throw in a filtering surgery. Otherwise, I would tend to err on the side of a lens extraction because it will let the iris fall back. High lens vault, there is a low threshold for lens extraction. This is the only occasion where I'd say lens extraction, rest I'm calling cataract. Plateau iris, UBM, to document it if you have access to it, consider PILO as a medical therapy option here after PI. Any cataract in any closure, go for cataract surgery. That I have no problems with. PACG, essentially the same thing. Any cataract surgery. If the IOP is uncontrolled, no cataract. Medical treatment, IOP is still not controlled, significant PAs, go for filtering surgery. If there's a high lens vault, add on lens extraction as well. It makes life easier in the post-strap time, as Kiran told you. So what do you do? PACS, PAC, low incidence, so watch or do PI either way is justified. PI does not prevent all closures. It does not absolve you of need for follow-up. Clear lens extraction role is still very unclear. There are no hard and fast indications described in the literature, but there are situations where you would want to do it when there's a very high lens vault, maybe above 1 millimeter lens vault, you would consider that even in the absence of a cataract. Definitely, once you have a cataract, you would go for a cataract surgery. I would say early cataract surgery. Wait for a symptom that can be attributed to the cataract in the patient. We have had great advances in the IOLs, aspheric, dealing with all sorts of aberrations, but we are still not perfect. The patient's crystalline lens does give the patient a better vision than the best of IOLs we can put in. Also, here when you have a lens vault of above 1, you've got an anterior chamber of less than 0.5 depth. And the cataract surgery we are talking about is a small incision that is a phaco. Doing a phaco in a 0.5 depth AC is not a joke. It's not for the faint-hearted. I actually took more time for these clear lens extractions than a hard brown grade 3, grade 4 nucleus cataract, which I do routinely. So early cataract surgery, no problems. Lens extraction, it's for a very experienced cataract surgeon only and should be taught about a lot before we go straight for lens extraction. But it still does work. Thank you.
Thank you, sir. That was really informative and clearly explained the pros and cons of clear lens extraction. That finishes the session. So we are open for discussion now.
I think the Eagle study gets attacked on all glaucoma forums. Every glaucoma forum, everybody attacks them. Yeah, they were very sneaky in the sense that with the initial set point of 1.75, they looked at 1.18, and there a lot of emphasis on quality of life indicators. Anyway, but it does alert us to the role of lens. I mean, I was just thinking that for your antipsychotic case, Before the Eagle study, the pre-era Eagle study, we might have
study is giving a wrong message. Clear lens does work. But they have brought it in like Kiran said, roundabout way. By the way, Eagle study, they have diagnosed closure and in their data that they have finally presented, they have not done gonioscopy on all the patients. How do you diagnose closure and bring out a glaucoma study without having gonioscopy in all the... I mean, I could have gone on 10 minutes on the Eagle study criticism. I just put in 2 points and got away with it because as a study, it is not a well-done study. But having come into Lancet, it is a high-impact journal. Everybody got alerted to lens and we started looking at the lens. They have done a good job there. Other thing that I would do for a trap, I would do a slow guarded paracentesis to decompress a globe as the first step. Like Kiran has got a good memory, but then if I make the flap, the next thing I do is I'm going to enter and I won't have a paracentesis in place. So I do that before I start the trap itself because that is your lifeline. That is what you need when you want to retrieve a situation at a later time when the eye is hypotonic.